Okay. A warm good evening, everybody, and I hope you can hear me and see me clearly now. Shall we get started, guys? This is a FMG recall sessions of the July FMG exam of 2025, and we had a significant number of questions in radiology this exam, and they were pretty much doable also. If you have, seen the lectures and followed the lectures, I think you must have got most of these correctly. Let's get started with the first question here. Please let me know what did you answer for this. A 6-month-old infant is brought to the emergency department with multiple injuries, including bruises on the chest and abdomen and swelling around the knee joint. The parents report a history of a minor fall at home. On examination, the child is irritable and has tenderness over the multiple sides. X-ray reveals multiple posterior fractures and the tibia and femur at different stages of healing and subdural hematomas on neuroimaging. So a very detailed history was given, and you're having multiple fractures given in the patient, and there is a presence of subdural hematoma. And also, if you look at the image, you are showing this metaphyseal corner fractures, and such multiple fractures only after a single fall, right? This would not be a osteogenesis imperfecta. This would be classic battered baby syndrome. Osteogenesis imperfecta, this will have diaphyseal fractures. Battered baby syndrome will have metaphyseal corner fractures. Right? Metaphyseal corner fractures. So, and remember the presence of subdural hematoma. Remember when we study about subdural hematoma, we know that subdural hematoma is due to the rupture of bridging veins. So when you are shaking the baby or battered baby, there'll be rupture of these bridging veins. And what is the type of bleed that occurs when there is rupture of bridging veins? The subdural hematoma. So presence of subdural hematoma also is a clue towards battered baby syndrome. So this is battered baby syndrome, the first one. Now let's look at the next one. What did you answer for this question, guys? A 50-year-old patient presents with continuous headache, nausea, vomiting, and altered sensorium. A non-contrast CT of the brain was given with hyperdensities as shown in the image. What is the most likely diagnosis? I hope you have done this easily. Continuous headache, non-contrast CT showing hyperdensities in the basal cisterns, sylvian fissure, basal cisterns, right? So this is the star of death that you have, star of death in the basal cisterns, star of death that we study. All of this is classic subarachnoid hemorrhage. Please remember, subarachnoid hemorrhage has the features of meningism. So because of the irritation of the meninges, there is blood in the meninges, you will have nuchal rigidity, neck stiffness, right? And this headache, the worst headache of his life, thunderclap headache, all of these features will be there in subarachnoid hemorrhage. So this is subarachnoid hemorrhage. So this is classic star of death appearance, subarachnoid hemorrhage. I hope, and I'm glad most of you have answered it correctly. This was a new question that came in. It's a physics question that came in. The question was, in radiological physics, which of the following best describes electron volt? And electron volt, if you remember, we studied that in kilo voltage. What did we study about this? This is directly proportional to energy of X-rays, right? So directly proportional to energy. So basically, the electron volt is the energy that is gained when an electron is accelerated through a potential difference of 1 volt. So the definition of electron volt was asked. It is the energy that electron gains when it is accelerated through a potential difference of 1 volt. This is electron volt. This is the third question that we have. This is a question from radiotherapy. What type of energy is used in a linear accelerator for cancer treatment? Linear accelerator or LINAC. This is used to produce X-rays. The most common method of cancer radiotherapy is X-rays. So they asked you what is produced by LINAC, linear accelerator. This produces X-rays. And to generate X-rays, we have to create electron beam, right? To generate X-rays, first electron beam. You study the generation of X-rays. Front cathode is there and then anode is there. So first electron beams should be generated and then the X-rays will be generated. So both electrons and X-rays are produced by what? Linear accelerator. The linear accelerator, also called as LINAC, produces both electrons and X-rays. Neutrons and protons, these are produced by cyclotron. X-rays are generated by linear accelerator during cancer teletherapy or external beam radiotherapy. And what produces gamma rays? Gamma rays are intranuclear in origin. And for cancer treatment, we use cobalt-60 to produce gamma rays. So please remember this. This could be in the future. Linear accelerator for X-rays and electron beam. Cyclotron is used to produce protons and neutrons. And cobalt-60 is for producing gamma rays. Okay, so I hope this you have done right. Fifth one. Now, this was a simple question. There was a child with cyanosis, and they gave you a radiograph showing the classic boot-shaped heart. You can see a concave pulmonary area, right? A concave pulmonary area, upward cardiac apex. This is boot-shaped heart or Coren-Sabot. This is feature of tetralogy of Fallot. So the Coren-Sabot or boot-shaped heart. Boot-shaped heart. This is tetralogy of Fallot. The next thing that we have now, this is a orthopedics question that you had where you had a patient who is having pain and in the lower limb, in the tibia site, they showed you a lucent area with a sclerotic rim. So when you see a lucent area sclerotic rim in a metaphysis of the bone, in an immunocompetent person, right? A healthy individual, a immunocompetent individual having a metaphyseal lesion with a lucency with a sclerotic rim. This is classic Brody's abscess, Simple bone cyst, what is the finding that you have? You have a unilocular lesion. And what is the findings that you have in simple bone cyst? Fallen fragment, as well as the trapdoor, right? So fallen fragment or the fallen leaf sign and trapdoor sign. These are features of simple bone cyst. Unreasonable bone cyst is also in the metaphysis, but this will be multilocular. And this will have fluid levels, hemorrhagic fluid and cystic fluid levels. That would be unreasonable bone cyst. And this will be in immature skeleton, less than 20 years age group. Chondroblastoma is an epiphyseal lesion in less than 20 years age group. Immature skeleton, unfused growth plate, that is chondroblastoma. So here, this image was a Brody's abscess. They gave a Brody's abscess question. Then a radiological anatomy question. They asked X-ray of the foot and they asked what is a marked bone shown to you. So this bone, which is boat-shaped bone that you have, this navy shape or boat-shaped bone that you have, this is your navicular, right? So this is your navicular bone, right? So this is simple navicular bone. And the talus, the bone that is articulating with the navicular, that is the talus, right? The talonavicular joint. And anterior to the navicular bone, you have the three cuneiforms. And laterally, articulating with the calcaneus, you have the cuboid. This is the cuboid bone on the lateral part. So remember the navicular bone. They marked the boat-shaped bone. That was your navicular bone. The boat-shaped bone that you have, that is your navicular bone. Next, a simple question. They asked you to identify the radiological investigation where the contrast was coming into the kidneys and excreted into the ureter, reaching the bladder. So you are seeing an intravenous pylography image, right? So intravenous pylography or intravenous urography image. So intravenous urography, it has two stages. You will see initially when the contrast goes into the kidney, you will see the nephrogram stage. And once it comes into the pelvic calcium system, this is called as the pyelogram stage, right? So intravenous urography has nephrogram and pyelogram stage. So image of pyelogram, the pelvis and the ureter was seen in the kidney. Simple. Next one, ninth one. Now this was an important question. They asked you that there is a patient with flank pain, recurrent urinary tract infection, ultrasound shows hydronephrosis, and the clinician wants to evaluate renal function and check for urinary tract obstruction. Which of the following investigations is most appropriate investigation to evaluate renal function, and to check for urinary tract obstructions? So if you remember the nuclear medicine classes that we discussed, in that I teach you about the nephron, right? How the isotopes act in relation to the nephron. So imagine this is the cortex, this is the medulla of the kidney. DMSA gets filtered from the glomerulus and is reabsorbed into the cortex. So it will tell you about cortical function, corticomedullary differentiation, cortical scars can be evaluated by DMSA. DTPA gets filtered from the glomerulus and is excreted as such into the collecting duct, into the urine. So it is a reflective of GFR. It is neither reabsorbed, neither secreted into the tubules. It is neither reabsorbed and neither secreted. So it exactly reflects GFR. So DTPA scan is for GFR. But if you see MAC3 gets filtered from the glomerulus And MAC3 also comes from the tubules, undergoes tubular secretion. So it tells you glomerular function also, and it tells you tubular function also. So the best for renal function, showing both glomerular and tubular function, right? The tubular secretion to look at renal plasma flow, renal perfusion, and renal function. We go for mercaptoacetyl triglycine. What does MAC3 stand for? Mercaptoacetyl triglycine. So if they ask you glomerular function, that would be DTPA. If they ask you cortical function, that would be DMSA. But best to look for the radioscope study for renal function. The radioscope study for renal function is your MAC3 scan. MAC3 scan. Next. Now another very easy question. I hope all of you have done this rightly. They gave an IVP image showing dilatation of the distal ureter, giving a classic cobra head appearance or adder head appearance on IVP. A cobra head or adder head appearance, this is uretro-C. So I hope you got that right. And posterior urethral wall, this would have given keyhole appearance, right? This would have given keyhole appearance on antenatal scan because of the posterior urethral wall. This is cobra head or adder head appearance. Cobra head or adder head. This is uretro-C. Let's look at the next one. Simple. I don't know why the examiner was very kind with you with radiology. So they were just asking straightforward investigation. What is the investigation shown to you? And this was a mammography image. Okay, mammography image that we have. Next thing. What did you answer for this? A patient with distended neck veins, absent breath sounds, hyperresonance to percussion, tracheal deviation to the opposite side. So when you have prominent neck veins, right? There is prominent neck veins. There is tracheal deviation to the opposite side. These, and if you look at the radiograph also, there is absent breath sounds on that side, and there is hyperresonance. So there's a lot of air inside. And you look at the radiograph also, there is absent bronchovascular marking, visceral pleural line. The lung seems to be collapsed towards hilum. So all of this is your tension pneumothorax. When you have pneumothorax with mediastinal shift or an unstable patient is given to you, either they give you the mediastinal shift or an unstable patient is given to you, this is a tension pneumothorax. And tension pneumothorax is a clinical diagnosis, not a radiological diagnosis. Tension pneumothorax has to be clinical diagnosis. So this is wide bore insertion, right? Wide bore needle insertion in the second intercostal space using a 14 gauge or 16 gauge needle. We go for wide bore insertion. It has to be a wide bore insertion, right? This is tension pneumothorax, because they gave tracheal deviation, distended neck vein, and you're thinking of mediastinal shift also. This is tension pneumothorax, and it has to be clinical diagnosis, not radiological. This is clinical diagnosis. So no X-ray, no CT. No X-ray, no CT, immediately put the wide. And he asked immediate management. Should be what? Wide bore needle. Next, 13th, a diabetic patient with facial pain, blackish discoloration around the nasal region. And the imaging was showing bone erosions, extensive paranasal involvement, and also on the contrast enhanced MRI. They gave a contrast enhanced MRI image, and you can see a black turbinate, the inferior turbinate. Look on the left side, there is contrast enhancement on the left side. So this is the black turbinate on the right side. This is the black turbinate. So when you have a diabetic ketoacidosis patient or uncontrolled diabetes showing this blackish discoloration, right, and a black turbinate on the imaging, this is because of an angioinvasive fungus, which is invading in that area, preventing the contrast from coming there. What is that? This is mucormycosis, rhinoorbital mucormycosis. Okay, so please remember black turbinate sign, and also remember how the image appears. The black turbinate sign. This is mucormycosis. Diabetes in the patient or diabetic ketoacidosis may be mentioned. Next, again a very common question, repeat question. A patient who had an injury to the eye after being hit by a cricket ball. He had double vision and especially problems, diplopia, when looking at the upward. So you can see on the CT scan, a coronal CT was given, and you can see the contents hanging into the maxillary sinus. So these contents hanging into maxillary sinus, this is what is called as teardrop fracture or bloat fracture or orbital floor fractures. So the answer here was teardrop fracture or bloat fracture or orbital floor fractures. And The best X-ray view is Waters view, right? So because the contents are hanging into maxillary sinus, the best X-ray view for orbital floor fractures or blowout fractures is Waters view. And what did you write for this? A person who had an occupational exposure to sand working in, a construction worker, and he developed chronic dry cough, and the radiograph was given. And what did the radiograph showed? Classic eggshell calcifications. You are seeing classic eggshell calcifications. Eggshell calcification. And we learn in our classes, eggshell calcifications are seen in what? Silicosis, sarcoidosis also. And you may see this in post-radiotherapy lymph nodes, also. So classic eggshell calcifications, this is silicosis. I hope you've got that right. Next, this is something that you all must have got it right. A trauma patient who is having poor Glasgow coma scale and non-contrast CT appearing normal. So CT scan is appearing normal, or it may show some petechial hemorrhages. They show petechial hemorrhages. A trauma patient who is having poor Glasgow coma scale, right? Unconscious patient. CT scan done after head trauma is appearing normal or shows only petechial hemorrhages. Strongly suspect diffuse axonal injury. And what is the investigation of choice for diffuse axonal injury? MRI. You will see petechial hemorrhages in the white matter, in the corpus callosum, right? So this is classic diffuse axonal injury, right? And to look at petechial hemorrhages, which sequence of MRI can be used? To look at petechial hemorrhages, which sequence of MRI can be used? Can anybody help me with that answer? Which sequence of MRI can be used to look at petechial hemorrhages of the brain? Susceptibility weighted imaging, right? So susceptibility weighted MRI. Susceptibility weighted MRI. The susceptibility weighted imaging, or SWI, looks at the petechial hemorrhages, the microhemorrhages in the brain. So this is diffuse axonal injury. Next, we discussed this in our women imaging, obstetric imaging part of radiology, and I hope you have done this right. So they basically asked you the definition of a missed abortion. What is definition of missed abortion? When the crown rump length of the embryo is more than 7 mm. If this is more than 7 mm and you don't see any cardiac activity inside. So when the crown rump length is more than 7 mm and you don't see cardiac activity, this is what is missed abortion or the failed intrauterine pregnancy. Remember two criteria. One is a crown rump length more than 7 mm and no cardiac activity. This is the answer. Or if you have a mean sac diameter, if you have the mean sac diameter, which is more than mean sac diameter, how much? More than 25 mm and no yolk sac. This is blighted ovum. This is called as blighted ovum. Okay, we'll put it here, blighted ovum. So these are the two causes for failed intrauterine pregnancy. One is when the crown rump length is more than how much? 7 mm and without any cardiac activity. Or when the mean sac diameter is more than 25 mm and no yolk sac. These are two important ultrasound criteria for missed abortion or a failed intrauterine pregnancies. Next. Now, this has been asked in the last FMG exam also. Okay, so in the last FMG exam, they asked the same question in a different manner. Now, this time they put it very straightforward. Fetal anemia is best diagnosed by Doppler assessment of which artery? And if you remember in the last exam, they asked which is the non-invasive method to detect fetal anemia. And the answer was increased peak systolic velocity in fetal MCA, right? In the fetal middle cerebral artery, So if you look at the middle cerebral artery, if you see high pulsatility or increased peak systolic velocity, and why it is occurring? Because of brain sparing effect of fetal hypoxia, right? This was fetal MCA Doppler to non-invasively look at fetal anemia or fetal hypoxia or hydrops fetalis. So this is fetal middle cerebral artery. Umbilical artery Doppler, this is used to evaluate IUGR or the impending fetal demise. Uterine artery, if it shows diastolic notching, this is to evaluate preeclampsia or the pregnancy-induced hypertension that we have. Whereas middle cerebral artery is for fetal anemia. So we've done that in your obstetric Dopplers, right? So we discussed all of this briefly. Okay, so remember, whenever the fetal anemia is there, all the periphery goes into vasoconstriction. The cerebral circulation goes into vasodilation. Bring the blood all towards the cerebral circulation. So all the cerebral vessels will show increased peak systolic velocity or high pulsatility. And we trace mainly the middle cerebral artery because it is easy to trace in the sylvian fissure. So you can see this increased peak systolic velocity or high pulsatility in the fetal MCA, suggestive of fetal hypoxia or anemia. The fetus is trying to spare the brain by causing cerebral vasodilation. There is vasoconstriction in rest of the body, but there is vasodilatation in the cerebral circulation, right? Next thing, what is the next part? What is this question here? A 25-year-old male presents with headache and visual disturbances. MRI of the brain shows cerebral hemangioblastomas. An abdominal imaging shows renal mass, suspicious of renal cell carcinoma. And the MR image showed cerebellar hemangioblastomas. So this was a syndrome that was asked. This is von Hippel-Lindau syndrome. Von Hippel-Lindau syndrome. What is von Hippel-Lindau syndrome? What is von Hippel-Lindau syndrome? This is hemangioblastomas, increased risk of bilateral RCCs, right? Clear cell RCCs, pancreatic cyst, multiple pancreatic cysts, pheochromocytomas. And remember it as Hippel. Can you see the name Hippel inside? So this word I'm using, Hippel. So hemangioblastomas, increased risk of bilateral RCC, pancreatic cyst, pheochromocytomas. And what is EL? Presence of endolymphatic sac tumors. Endolymphatic sac tumors in the patient. So this is von Hippel-Lindau syndrome, the chromosome 3 defect that we have, chromosome 3 defect. So this is von Hippel-Lindau syndrome, von Hippel-Lindau syndrome. Remember, cerebellar hemangioblastomas, retinal hemangioblastoma. Because of retinal hemangioblastoma, there is also visual disturbances, right? So retinal hemangioblastoma, cerebellar hemangioblastomas, and bilateral RCCs. Retinal hemangioblastoma, cerebellar hemangioblastoma, bilateral RCCs. This is von Hippel-Lindau syndrome. Now, they said there is a MR image showing the placenta, which is abnormally adherent to uterine wall and penetrated through the myometrium into the bladder, going into the surrounding tissue. What is this? What is this? What is this? What is this answer, all of you? What did you write here? Remember, the investigation of choice for placenta accreta, percreta, this is MRI. The investigation of choice. We study pelvic adenomyosis, placenta increta, percreta, right? All of this is MRI. Now, when it is invading into the wall, so it is clearly saying it is invading the wall and the surrounding tissue, you are dealing with placenta percreta. That is all going towards the cirrhosis of the uterus and going into the surrounding area. So they mentioned uterine wall and the bladder. This is placenta percreta, placenta percreta. Then this was a clinical case, as a surgery question, give clinical scenario given. They showed you all the features of testicular torsion. A very adolescent, very young male coming with severe testicular pain. And so what is the most appropriate step? So basically, when you have a acute scrotal pain, you may have, when you have acute scrotal pain, please think of in a young patient. In a young patient, when you have acute scrotal pain, you think of two things, right? One is it could be testicular torsion, or you can have acute epidermolysis. Epidermolysis will have increased flow in the testis. When you do a Doppler, you will see increased flow in the testis because of vasodilation, right? Itis. So epidermolysis will have increased flow in the testis, whereas torsion will be absent flow. Torsion will show you absent flow. So here the answer should be Doppler. So you'll have a Doppler ultrasound, okay? The duplex ultrasound or Doppler ultrasound. Duplex ultrasound or Doppler ultrasound, right? So that should be the thing. Then there was one question just asking what is a fracture. It's an orthopedic question. Between the two trochanters, there was a fracture, and they asked you what is the fracture. An elderly person with a fall at home, what is a fracture? The answer should be intertrochanteric fracture. So these were just correlated questions, but the rest of the things, right, were more of a lot of radiology. So radiology being an integrated subject will definitely help you in your scores, right? So I hope the exam was, I feel, pretty doable. I hope the results will also be good. The paper was moderate. Yes, not very easy, but we expect at this level to be able to, answer most of the questions. Please quickly tell me in your comments how many could you get? How many could you get? How many correct could you get? Please let me know how many you could get right out of these questions. I think Megha is very, please, focus on your academics and it will help you rather than, having a focus will help you more than, being unnecessarily disturbed by random things, non-genuine things. Okay, so start focusing on what is important, and it requires a sincere, humble effort, and you should do fine. Okay, and all of these have been discussed. If you go into the class notes, the best way is to go back to your class notes and check what has been taught and all, and you will see all the discussion that has been there is already in the notes. And if you have, go back and check that out, and you will see that whether it is helping or not helping. Right. So I think 17 is a good number, right? I hope this will give you a lot of cushioning to see that you score well in your exam. Okay. I wish you all the best for your upcoming results, and keep working, and stay hopeful also, right? So hopefully you'll have good exam, and do connect to us after you clear the exam. We'll be happy to hear from you, right? All the best, guys. Okay. Thank you so much. Okay. Take care, guys.